Welcome everyone to today's webinar. I am Ayla Ellison, Managing Editor at Becker's Hospital Review. We will begin today's webinar with a panel-style Q&A, and we'll have time at the end of the hour for a question and answer session from the audience. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your question. Additionally, in about a week following the webinar, of the presentation to the email you used to register. At this time, it is now my pleasure to turn the floor over to Bob Howard from Optum 360 to introduce today's panelists.
Good afternoon or good morning for some of you. Today's panelist, and I'll start this off, is myself, Bob Power. I'm currently the Senior Vice President of Strategic Client Relationships at Optum 360, and I've held that role for a little over a year. Prior to that, I was a Regional Chief Financial Officer at Northwell Health, and a portion of my previous role was to strategize with our managed care group to try and stay one step ahead of the managed care companies as we negotiated new contracts, looking at where to look for rate increases, what kind of protections we wanted in there, trying to think about what is the managed care company going to do next. So with that, I'll turn it over to our other panelist, Mike Santoro.
Hello there, Mike Santoro here. I'm the Senior Vice President of Commercial Claims and Appeals for United Healthcare. So as Bob introduced himself, he obviously gave an outline of what he was responsible for, and I'm obviously on the payer side. I've spent 23 years in claim operations, and although I was never directly at the negotiating table, I supported the network teams all of the time, and my job was to figure out what Bob was up to in terms of his strategy for essentially maximizing his contract performance. And then I would turn around and go inside the operation and build out programs to make sure that I was doing all the claim cost containment work that needed to be done within the relationship. So it's always funny as we started to talk to one another and understand what each of us did, how we were essentially trying to accomplish the same things from completely different places. So in my 23 years, I've managed all aspects of claim operations, from intake, both electronic and paper, through claim adjudication, both automated and manual, the claim cost containment programs, which would be fraud, waste, and abuse, recovery operations, and then finally the financial payment systems. And inside of the entire claim process, I've owned, the claim editing, configuration, as well as provider data load and maintenance. So my experience and background is pretty robust, and and I essentially bring a lot of depth into the conversation when it comes into this payer-provider collaboration type conversation. And with that, I'm going to turn it over to Jennifer Eigel.
Thank you. So again, Jennifer Eigel. I'm the Vice President for Dignity Health Operations with Optum 360. Prior to that, I was also working for Dignity Health. I was similar to Bob Power in that I was trying to figure out what Mike was up to. We spent many time at Dignity Health working with our aged payers, with our high volume payers, trying to partner with them and trying to understand how we could reduce our AR for our largest managed care payers, trying to navigate all the different appeal processes and trying to understand how we could, as a system, come up with better solutions for addressing some of our largest payers as opposed to, just the claim-by-claim level appeals by our individual follow-up reps. So again, it's been great to come full circle and now have both sides on the team, because I think it's been a great perspective and able to see how we all really want the same thing, and we're going to walk through some of that in this discussion. But it's I think been very interesting to see how all this has progressed since then.
Well, thank you so much for those introductions. And with that, let's go ahead and get started with our first question for the panel. And the question is, where do you see the most friction between payers and providers? And feel free to comment on the biggest challenges and opportunities as well. I'd love to hear from all three panelists on this question. And Bob, would you care to go ahead and kick things off?
Sure. I think one of the biggest areas we see friction is in clinical decision making. It's so common these days that physicians in hospitals will decide on admitting a patient. They're there in the emergency room with the patient. They're looking at the vitals. They're actually touching, feeling the patient. They make a decision, a clinical decision to admit. Then upon billing, somebody who could be half the continent away will decide that it wasn't medically necessary or appropriate and deny the case. And so often you'll talk to physicians and they're like, you know, how dare, they don't realize that you do have physicians on board these insurance companies. And so their perception is you just have a clerk in the back end who is just making a determination that the patient didn't need to be admitted. And so to me, that's one of the areas where I see the most friction today between payers and providers who are, you know, people just deciding to downgrade cases.
And Mike, what's your take?
Well, I mean, I obviously share that sentiment. I'm not for every claim that comes into our organization as either a reconsideration, and a reconsideration, when I use that term, is someone from the provider side calling us and say, hey, did you pay this right? It's that step before appeal, right? So there's nothing appealing about appeals. I really don't care for the whole process. It's a necessary evil of the environment that we live in, but what are we basically looking at in appeal? And generally it's a level of care conversation, you know, to Bob's point around, you know, what's the appropriate level of care for how that patient presented, and can we get to a common meeting or agreement of what clinical criteria we're going to agree to essentially apply evidence-based medicine and come to an agreement around how that patient, our member, should be treated. And a lot of this requires us, you know, I've been in this business for a long time. I spent 5 years in provider relations. I've spent my entire life trying to reduce rework, including the appeals process. And to be truly collaborative, as we're learning in this relationship with the Optum 360 team, we sort of have to step outside of our processes. I mean, I think that's really one of the biggest things that I've learned, and really stand in the shoes of the providers and look at it from their point of view as well, and figure out how to come to a better collaborative interaction between the provider and payer, so that we streamline the process, taking out the misconceptions that go on between both parties around what the other is trying to do. You know, it's much to the it's the opposite really of what people think. We're really trying to figure out how to get to yes quicker without having to go through the multiple touches. And I think that's one of the things that we see most clearly is that, you know, we're not looking at how we get this together. We're trying to, we spent a lifetime, at least in the United Healthcare side, I can tell you, trying to get providers to adapt to what our processes are, right? And provider relations taught me something very clearly, right? If I'm standing inside a provider's office, we are not the only payer doing business in their office. They've got to follow the rules and processes for, you know, could be a dozen or more other payers in their offices, and it can't be just all about us wanting to have a very rigid process for providers to follow. So I would say that that's really the biggest learning for me in terms of the challenge that we need to accomplish, is like figuring out how to meet our providers somewhere in the middle to get to a more collaborative end result to manage the process better.
Well, thank you, Mike. And Jennifer, I'd love to hear your perspective as well.
I think pretty similar along the same lines. I can see a lot of friction with the clinical world, especially being on the provider side, where the providers feel somewhat held hostage to the clinical decision making by their physicians in the hospitals, feeling that they have to trust their physicians are making the right decisions for their patients, and then having to navigate the kind of administrivia of it on the other side. Now that we've treated your patients, we would like to get paid for it. in trying to both work with the payers to follow their processes, but also that frustration of also having to work with providers where we know that there's some improvement that needs to be made, I believe for many providers, on how do we determine that level of medical necessity, that level of care, making sure that our care coordination teams are working with that. So I think even some of our internal issues can have an impact on these discussions with our payers. So I think that adds to some of the frustration. And I think some of the other is really the, sometimes it seems like a maze of processes to follow through for appeals. Every payer, of course, has their own. Sometimes even the individual products within a payer will have different approaches, different templates that have to be submitted, different timelines. Restarting the clock on appeals. Well, we missed one medicine charge. We need to completely resubmit the entire appeal. So sometimes it feels that we are just spending so much time of our side, not to mention the payer side. We're both spending staff time re-reviewing something that may have happened 6 months ago where we feel it was medically necessary and it occurred, and now we're still reviewing it. And again, this is a friction between the payers and the providers, but it's also an opportunity to take a step back and look at it and say, well, the provider has already had these costs. The payer wants to protect and make sure that the costs were appropriate. But how can we make this more efficient? Because right now we're just both sides are spending money sending itemized statements, medical records back and forth to each other. And so now we have a whole army on both sides sending paper back and forth and denying, reappealing, and trying to understand those processes. So I think that's where we have a lot of opportunities to understand where are we starting to get mired into some of that rework. What are pieces that we can carve out and say, you know what, 100% of the time we agree on X, Y, Z. Let's carve out this issue and figure out a way to get that resolved more cleanly and start tackling those issues that we can find a common understanding of. Because again, we both have some common incentives in that we want to decrease the cost to collect. We want to decrease the amount of time that those claims are outstanding. It impacts not only our accounts receivable, it impacts their patients and their clients as they're having to deal with trying to get their claims resolved. So I think that's one of the opportunities that we have is finding where we do have those aligned incentives where they may not seem as obvious, carving those out, and then finding solutions for those.
Fantastic. Oh,
I'm sorry. This is Bob again. I just wanted to add another comment, if that's okay. You know, one of the other areas of friction or challenges that we do have, you know, because we've been talking a lot about providers as hospitals. When I look at the physician side of it, delays in getting physicians credentialed onto insurance plans as well. You know, my old role, you know, we were, as many health systems are, heavily involved in acquiring or recruiting doctors. And you could take a doctor who had a private practice, who was on all the insurance plans, employ them, and then have to go through the process of re-credentialing them on all those insurance plans. And in some cases, that could take 9 to 12 months, at which time you're unable to bill, you're out of network. So it led to a lot of challenges in recruitment and cash flow. And there just has to be an easier way that when doctors are migrating to employment of health systems, that shouldn't have to take as long. Their credentialing should easily just roll over, and that's an area we need to address as well.
Well, fantastic, and thank you for those additional comments. We can go ahead and move on to the next question now, and it is, what steps are your organizations taking to correct the issues? And if you could also discuss the benefits that have been achieved due to these efforts, that would be great. And Mike, let's start with you, and then let's hear from Bob on this one.
Sure. From my standpoint, every time I'm involved in a conversation around getting to a better outcome, it usually centers around one general principle: cash is king, right? And I think we've talked about it already as this conversation began. It's like the provider always wants to know, where's my money, when am I getting it, how am I going to get it? So for me, the achievements that we're realizing are obviously financial, not just from a cash flow perspective, but also from a reducing the contacts or touch points of getting to the right solution quicker, right? So that we essentially figure out what's required by getting to understand, to Jennifer's points earlier, what's required and when. A better level of transparency within each of our contact centers, our web portals, our published external policies. I often find that we get into these, we internally in United Healthcare get into conversations around, hey, we're not going to tell the provider how to bill, right? So what happens? You submit a bill, and to Jennifer's illustration previously, we keep going through this cycle of requesting additional information until you actually send us what we're looking for. But nowhere do we actually tell you, for this level of service, this is what we're looking for. For this type of service, this is what we're looking for. And internally, we don't want to cross a line and start to instruct providers how to bill, but on the flip side of that, we also need to articulate what's required in order for our service to be payable. And that's one of the places where we tend to find a great deal of conversation. And I myself, being part of this collaboration, have pulled policies and procedures out of both the call center, out of the clinical teams, out of the claim operations, and tried to look at what we were saying at every one of those levels regarding the service that was being discussed, to figure out if they were all in alignment with one another to begin with, right? Because sometimes that's an issue. What we say in the call center may not be the same as what we're processing to within the claim organization, or what we're talking to within the clinical organization. So making sure that we've got an end-to-end alignment of those three primary components of the claim process, and really just trying to take as much of the touching out of both sides. Again, it's not just about us as a payer and looking to reduce our administrative dollar, but figuring out how to help the provider not spend the time doing the multiple reconsiderations, appeals, and what have you, trying to get at the one single thing that we're trying to get to, which is, where's the money? I provided a medically necessary service for one of your members. There's a benefit that's payable. How do I access that benefit in the fewest number of steps? That's what what I see as really the benefit that we're deriving from this collaboration.
And Bob, what do you have to add here?
So, as I look back what we were doing, we would have joint operating committees between Northwell and the various insurance companies. We had like a 5-step process of escalation of disputes between the insurance company and Northwell, which would end up, at some kind of a settlement, potential lawsuit, and perhaps contract termination at worst case scenario. Now what we're trying to do through the payer-provider collaboration is nip it in the bud and saying, okay, there's a disagreement right now on when a patient should be admitted. So let's get the doctors in the room and come up with an agreed upon admission criteria. So I actually sit in meetings with physicians from United Healthcare and physicians from Northwell Health, and we're picking DRGs, top 15 that get denied, and let's figure out, what should the admission criteria be? When is chest pain severe enough that it requires an admission versus not? And to the extent we can get this agreed upon earlier, it's going to result in less downgrades. It's going to result in less frustration for the physicians. It's actually going to result in better patient satisfaction, because think of yourself or your aging parent. They go to the hospital, they come home, they get their EOB, and they say their care was denied. Now, they don't know what it means to them. All they know is, I was in the hospital, they're denying payment. Oh my God, somebody's going to come after me for whatever the bill is going to be, even though that's not necessarily how it works. Most people don't know how it works. So you're really adding fear into these folks unnecessarily. So let's get it right the first time. as Mike had indicated, let's see more cash, let's accelerate the cash, and let's reduce the amount of cost to collect, because now I don't have to hire a bunch of folks who are going to write appeals, first, second, third level appeals. On the insurance side, they don't need to hire a bunch of folks who are going to deny cases time and time again. Some of the other steps we're looking at is, when should an authorization be required? Last time, I still find it kind of crazy that we require authorization for women to have babies. It's going to happen. It's not that as much as it might be perceived elective, the woman's going to have a baby. Do we really need to get an authorization from an insurance company for that to happen? I mean, these are joyous times in a family's life, and the last thing they would want to hear is, again, we have not secured an authorization. Similarly, on the other side, if somebody is diagnosed with cancer and requires extensive surgery, the last thing that patient needs to deal with is the fact that an authorization was not issued and that they have to run through hoops in trying to get the authorizations. So when should authorization be necessary versus just assumed it's right? What if we have really good doctors in place that the insurance company can trust, and trust is a key word in this partnership, that the insurance company can truly trust that doctor is going to do the right thing with regard to admission or outpatient or observation status every time. And so it's not required for certain doctors to have authorizations or certain procedures to have authorizations. That's the kind of work we're doing today, where I think it will just make everybody work better together. It'll get rid of a lot of the cost of inefficiencies, and I really do believe it can improve the patient experience.
Well, great, and thank you both for your comments there. And moving on to our next question, what strategies or changes would you recommend to other payers and providers as they work to improve collaboration? We would love to understand where to start, how to go about change, and what solutions are out there. And Jennifer, would you like to kick things off with this question?
Sure. So in terms of where to start with this, I think most payer providers have meetings where they have forums to go through various updates, process updates, escalated issues. If you don't have that, obviously you need to start with getting a form of that. But beyond just coming at this type of process with I'm a provider, I want to get my claims paid, or I'm a payer, I need the provider to stop doing X, Y, Z. It really needs to have both people come to the table with an open mind of, I'm going to come to learn what we can do differently and how we can simplify the process. And so in starting with some review and analysis of some of the claims that are going through and impacting your AR, so pulling some historical trends to understand what are some common areas that lead to disruptions in the revenue cycle, where there are either repeated workflow items required, both on the provider side or on the payer side. And I think this has to be done on both sides. It has to be an exercise done at the payer and an exercise done at the provider. Often the provider will say, why do you rebill claims? It seems like every month. And the provider will say, why is it every time we call you need a different itemized statement or another authorization? So if we at least get through that initial analysis of here's the top 10 issues that are causing some rework and angst along my staff, let's talk about if there's ways, if maybe we have overlap on some of those items, and let's talk through the individual areas where we can solve them together, where we do, again, as I referenced before, have those aligned incentives, because the payers really don't want to have to pay for staff to sit there and process claims repeatedly over and over again, and again holding out their members' finalization of their claims while we continue to hire staff to send the information over. So you can find those areas where you have the aligned incentives. You target those and again work towards how can we fix it? How can we prevent some of this rework? Some of it may require a few additional or a different step on the provider side. Some of it would require steps on the payer side. And again, if you come at it, and I think in my opinion, in a more collaborative manner of how can we do this differently together, that's where you find those opportunities to get a couple successes under your belt, even if they're little ones to start out with, and then you can start tackling some big ones, because there are some big ones out there where we find, you know, payer X denies this service for authorization, and 99.9% of the time, or maybe even 100% of the time, our appeals are successful. So let's talk about there's a better way to do this. And those are the more kind of meaningful one, that once we prove the concept with some of the individual kind of startup ones, you can get to the more meaningful items that are going to have a more impact on accelerating the cash flow for the providers and for simplifying the process to the payers. But then again, you know, making sure that you're going to, there's going to be give and take on both sides. So if the payer is saying, well, we're drowning in duplicate claims, somehow we're getting those sent every 15 days, it seems, looking in your own systems and seeing if there's improvements you can make to your own process that's going to help get that partnership across the aisle.
Thank you, Jennifer. And Mike, what would you like to add?
I think Jennifer hit on all the right points, right? It's and I've spoken to it already in a couple of places. It's really, you know, I'll talk about why I got involved at my level, right? I know that there are plenty of people at lower levels within the organization that can grind through the details, as both Bob and Jennifer have described, right? You submit a claim, we essentially process it, and there's an outcome. That outcome might be partially paid, might be partially denied, it might be asking for additional information. All I know is that the provider didn't get what they expected and there's more work to be done. And then it might go through that reconsideration process, and then the first level appeal, second level appeal. It's the grinding of the claims, as I call it. So I myself needed to be involved at a very senior level to do all of those things that I was talking about earlier, in terms of looking at the what's happening, where it's happening, and question, is this really appropriate, you know, for us to do at this point? And are our talking points aligned? Are we requesting the right information at the clinical stage? Are we looking at all of the information within the claims adjudication process? Are we understanding the benefits and how the claim will be paid from the call center side, and looking across to those three organizations to make sure that all of the information that we're supplying, both pre-service, concurrently, and post-service, are all aligned in saying the same thing? And as you could probably appreciate, United Healthcare is a an accumulation of many other acquisitions, and we all have, there's a bunch of claim processes and claim platforms, and they're different from plan to plan and region to region across the country. So getting alignment there has been one of those things that has proven to be something that it's not simple for just anyone to do it. Somebody at a more senior level that can navigate across our organization is really what is required. And I always walk into that conversation assuming that we are not right with how we've responded to the claim. I'm looking for a reason to change the process and policy so that we can get to that place we're going to get to anyway. As both Bob and Jennifer point out, it's like we eventually get to some level of yes. Let's just figure out how to get there quicker. But it takes a willingness across both organizations to have that conversation. And to Jennifer's point, you got to start somewhere. Starting small. I mean, I can tell you about the Northwell relationship. I've known it for the 23 years that I've been inside of the claim processing world, and it's been the same issues for the past 23 years that have been plaguing the whole resolution of cash. And finally, I said to myself, get involved at a level that's different than everything you've done before. Reach out across all those organizations that I keep referring to in terms of inside our organization, and look for a reason to get to yes faster. And we're doing it. It's not. I don't want to make it sound like it's easy, because it isn't. Right? It takes aligning a bunch of people across a number of different places, making sure that what we speak to and what we process to in the clinical areas, in the claim areas, and the call center areas are completely aligned. So
well, thank you, Mike.
That's what I would say there.
Thank you very much. And Bob, do you have anything to add here as well?
Sure. I mean, when you think about payers and providers, you've got decades of no trust between the two. And so, you know, when you think about where do you need to start, you need to start at a leadership level saying, we're going to make this work, and the leaders are all bought into making this work. You need to say you're going to start trusting a partner. And that's a big leap of faith at this point. And it's still even a leap of faith for us as we go through this process here between Northwell and United Health Group. But we believe we've got the right people at the table, and we've got executive ownership and buy-in at both levels. As Jennifer stated, start with some quick successes. You don't have, we talked about a lot of things and a lot of opportunities here for improvement. You don't have to just go after all of them right away. Start with 1 or 2 DRGs where you see a big increase in your clinical downgrades and say, you know what, let's try to fix that. Or let's talk about one type of item where we don't need to get authorization. Or how can we adjudicate claims quicker? It doesn't have to be the big bang on a lot of this stuff. You get one quick success and you watch it gain momentum, you watch the trust start to be built between the two organizations, and you're on your way. Engage your clinical staff. So often, you know, you may hear of organizations that have revenue cycle teams and they talk with their managed care departments, and where is there clinical representation in this? Because it's all driven by clinical decision making on whether you're going to be denied and what the coding and documentation suggests and how you're going to bill it. Make sure your doctors are included and your doctors are speaking with the physicians over at the insurance side of it. You have to make sure that it's beneficial to both of you. So sharing the benefits, whatever the outcomes are. Are you both going to reduce cost of rework by some of you by the insurance company writing the denials and writing the appeals on the provider side of it. So always look at, is it beneficial for both of us? Put down the defenses, obviously, but I think both sides need to understand each other's business challenges. Right? You think about a traditional acute care hospital, truly focused on inpatient care, now being driven more towards ambulatory. And its previous managed care rate structure might have been more driven towards an inpatient setting and not an ambulatory setting. So how do we bridge that chasm of moving more payment into an ambulatory world? Because the reality of it is, in a 5-day length of stay, the majority of your costs probably occurred in the first 24 to 36 hours anyway. And in an ambulatory world, that same cost in that same period of time is still occurring. You're not there for 4 days, so you're saving some money, but not as much as you would have saved in the initial part. So how do you move more reimbursement out of a 5-day length of stay DRG into an ambulatory setting or into a short stay type of setting or an observation setting? So those are the areas where I think I would suggest people start to look at how to collaborate and work better together. But the key here is that both sides are going to have to start trusting one another.
Well, thank you very much, Bob. And moving into our last panel question here, how do you expect the payer-provider relationship to look in the near future, say in 3 to 5 years? And are there things about this relationship you expect to be different or stay the same? And I'd love to hear from all 3 panelists. Bob, let's start with your prediction.
So, I mean, knowing the meetings I go to today and the people I'm working with today, I do believe that we will have agreement on admission criteria in the next 3 to 5 years on, I would say, a majority of cases that are admitted. We're still going to have those cases that are going to fall through the cracks. It's going to be the 80-20 rule. And it's for that small group that fall through the cracks that we're going to, it's probably going to get denied and appealed. And maybe there's a third-party intermediary that makes a determination right there as the patient's being admitted. How do we get information out to that third-party arbitrator to say, nope, this is an admission, and boom, done. And all your clinical denials are now eliminated. I think we will see reduction in what requires authorization going forward as we look through this and we look for inefficiencies in the process. I think 3 to 5 years from now, I think leadership on both the insurance and the provider side will be sitting down as partners and trying to understand each each company's long-term goals and visions and how they need to help each other achieve it. I mean, that's where we need to get to. We need to start working better together and figuring out how to spend the healthcare dollar more wisely. Those are, that's where I think this will get to in the next couple of years. And really, if you think about it, all it does, and what both sides really want, is improved patient experience. The patient wants to know what their out-of-pocket responsibility is going to be as soon as possible. They don't want to know about bickering back and forth. They don't want to wait 9 months till an appeal is settled and that they finally get their out-of-pocket expense figured out. Is it $1,000 or is it $3,000? They want to know more immediately. And we're both in this for the patient, so let's, make them the priority.
Well, thank you very much. And Mike, what are your thoughts?
I got to say that as I wrote down my notes around this particular question, I think Bob and I are in complete alignment on, where we're going in that next 3 to 5 years. And I think you led with it early on. It's that better clinical alignment, right? Getting out of this business where we continue to frustrate each other on stuff that doesn't matter in this process. And that both organizations have been talking for a while now around how do we eliminate all of the administrivia around, getting people to our members, your patients, to a better quality outcome. And I think, Bob, you articulated it very well, and I share that common thought and theme that you expressed.
And Jennifer, what's your take here?
I completely agree with what they've said. I mean, again, as I said prior, it's all about finding that common ground and finding areas that we can agree on it and move forward. That's just key, and gaining the clinical support and making sure that they're part of that team and decision making is important, because we know that there is a fair amount of clinical work that's done. Some of it may not be 100% necessary, so we need to make sure what we're doing to our patients is 100% necessary, and what we submit to the payers is 100% necessary, and the clinicians need to be a part of that discussion, or we're going to continue to chase each other around.
Well, thank you, Bob, Mike, and Jennifer, for that fantastic panel discussion. And we will now begin today's audience question and answer session. So as one more reminder, please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for. So we'll go ahead and start in with the questions that have already been submitted for today. And this first question is directed at all three panelists. And it is, could you give us an example of some of the strategies that you are implementing to improve collaboration? Are there specific programs?
Well, this is Bob. I think, as we went through the discussion, we hit on a couple of those issues with regard to physicians, getting the physicians aligned or looking at what needs authorization. So I'm not sure if there's anything over and above that I would really talk about. That's kind of where we are today. I'm sure as we continue to do root cause on some of the challenges we have together, new topics will pop up. New topics will pop up over time. As most of us move from a fee-for-service to fee-for-value, I'm sure we're going to start to see different challenges arise as to what are the measurements and how accurate are they, and what can you really control on measurements. So today we're kind of focused in the fee-for-service world of improving collaboration, but I'm sure over in the next 3 to 5 years, as we get this under control, we'll start to move into the fee-for-value side of it.
I think on the Dignity Health side, some of the kind of more tangible collaboration items that we've had would include the authorization piece for inpatient. So if we can come to kind of a set of rules that we can both agree to, because we all know that quite often our providers use Interqual, the payers use Milliman, or some internal group. And so sometimes we have different rules of what is an authorization, and so we spend half our administrative time going back and forth. Well, if we look at most accounts, we can probably agree on 99% of them, or 90% on them. So what we are working with at Dignity Health is, how do we get those set of rules basically codified in a group who can be, yes, you are the group who is the basically gatekeeper. If we follow these rules, then those are authorized, and we take out the administrative portion of the authorization process for those items where it's very, very clear what happened. So again, that's a part of taking away a piece of the complexity of the process. And then some of the upcoming initiatives that we're looking on partnering is looking at some of the common edits that are hit by the payer claims scrubbing system. How can we take some of those edits that we know that they're going to scrub for? How can we work with the payers to say, what can you tell us that you're just not going to pay, and we can integrate it into our billing system, and maybe not even our billing system, but maybe even get it up front to when the patient admits, so as upfront as possible in the revenue cycle, so that we get those common billing and claim denial issues tackled much sooner. So that's some of the stuff that's really exciting. It's still relatively new, and some of it is conceptual that we've been talking through how we could do this, but those are the type of kind of more tangible items that I'm really excited about. So we've done a lot of work on the collaboration, on the good old-fashioned roll up your sleeves and find areas where you can improve, and there's some overall claim processes that we've come up with, better workflows, better templates, better letters with the different payers. But when it comes to kind of brand new territory, I think the authorization piece, and then looking at how we can get some of the kind of payer edits moved upstream, up into billing, and then even at the time of service is where we see kind of that new horizon coming.
Yeah, no, I couldn't agree more. I have that same vision around moving edits as far up into the stream as possible. Whether it's at the initial part of the EDI stream, or to your point, Jennifer, even further into the billing system before it's actually submitted. It's getting that level of clarity into what's required by each of the products and programs that we service on the payer side, and bringing that level of transparency to the provider world, so that there's less for them to do on a post adjudication standpoint. I think that's where most of the advantage is going to come from. And we've brought a lot of operational resources into these collaborative relationships, including Six Sigma or operational excellence type resources, to figure out where we can pull the wasted time out of each side of the process.
Thank you all three for clarifying that and for your comments on that question. Moving on to the next audience question, it is, how do you measure improved collaboration? Is there a reduction in claims appeals?
Well, I would say absolutely a reduction in claims appeals, but really an improvement in the overall cash flow and the rate at which the AR closes. I think that's one of our primary measurements, is looking how fast we're closing the AR on the provider systems. Bob, if you had something to add.
No, I would agree with you completely on that. It's how fast is the cash coming in? The AR is going down. The aged AR is down. We're looking at the inflow of denials, not just the write-offs at the back end. But if we're making changes today and agreeing on admission criteria, the inflow of denials even before we have to appeal should be decreasing, and that's how we're measuring it.
I would agree with all those metrics. If you're not seeing an improvement in metrics, then we're not hitting the right projects. Both sides need to see an improvement of some sort, and we need to be able to measure it in order to continue to see the resources devoted to the project. So you need to be able to measure it, and it needs to be in terms of quite often either cash flow or staff resources that need to be able to measure to do that.
Well, thank you, Jennifer. And the next This audience member would like to know, during the appeal process, is the patient considered? And this question is for anyone who would like to jump in and answer.
So I'll start, right? I've run the appeals program, the appeals process for a long time, and I can tell you I personally look at appeals on a almost a daily basis, just for that simple reason alone, that I need to keep reminding myself that our processes have someone's life on the other side of it, and I'm always talking to the organization, not just the appeals organization, but all of the other organizations within claims processing and the call center teams around making sure that we don't lose sight of the life that we have in our hands that's on the other side of that claim. Because, you know, it's really about putting yourself in their shoes, making sure that they understand that, you know, we're trying to administer their benefits and hold up, you know, to what we were asked to do when they paid premium. And so I absolutely that is considered. I don't think we always do a great job at it, obviously, you know, but there's always it's a continuous life cycle improvement, I will say. One that is not just it's never an initiative in my organization. It is a constant cycle of looking at, you know, what's causing the appeal to occur and looking for a way to make sure that we avoid it as often as possible.
I would echo Mike's sentiment that, you know, the patient is always considered. If we had done a great job in the past, always, we probably wouldn't be having these collaboration meetings, right? So we know that it's impacting the patient experience. We know that they're getting statements that are confusing them and adding stress to their lives. So we've got to figure out how to do a better job between the two of us so that they're not getting kind of like the side effects of our challenges.
Well said.
Well, thank you both for your comments there. And moving on to the next audience question, it is, what advice do you have for freestanding imaging centers to maximize the payments they get per procedure, considering hospitals are more costly providing the same services?
Well, you know, it's an interesting question. I think you have to make a decision. Are you, regardless of what the hospitals are getting paid for the service, you have to make a decision on whether you're getting paid enough. As more and more price transparency comes into play, and people have higher out-of-pocket costs, they're going to be looking for lower cost, high quality options. And if your imaging centers are low cost, high quality, you may not be getting as much business as the hospital, but you will certainly over time start to steal market share, and that will bolster your bottom line. I truly believe that we are starting to see that, and people are starting to be more educated and shop around. So.
Well, thank you for your comments there. And the next question is, if you are not considered a large provider, how do you get the same level of service from the payer?
So I will tell you that all of the learnings that that I derive from both the Dignity relationship with Optum 360 and the Northwell relationship are not being applied just to those relationships. We are looking across the complete, you know, continuum of how we deliver service to make sure that the learnings are applied across the board. Obviously, we get into a greater level of depth and on how to service the business specific to Northwell and Dignity, but for whatever we can take out of the process and apply to the entire population, we absolutely do that. So I think all providers, you know, at some level are getting, or it's evolving to a better level of service for them. Definitely not as quickly, but it does roll through. I mean, that's one of the most difficult components of my job is to make sure that the teams that are working with these relationships more directly are bringing the learnings into the broader policy and procedure update organization that essentially is aligning what we do across the claim call center and clinical teams. So, like as I was describing earlier, we get to that that one-touch right experience that we're trying to get to.
Well, thank you for your insight in that area. And the next audience question is directed to Mike, and it is, we are still seeing restrictive coverage with some private carriers. There are LCDs with more accurate technologies such as cardiac, PET, and PI when compared to other inferior modalities. Medicare understands the value and how it favorably affects downstream costs, yet some private providers are still have limited access to superior technologies. What is the best way to approach carriers like yourself to ensure that patients can more easily receive care that leads to more accurate, safer results with increased patient satisfaction?
Wow, that's a question that I've never really considered. How to get to us? I don't know that I have a good answer to that question off the top of my head. I mean, I'm thinking about I completely understand why the question's being asked, because like someone as large as us is not easy to navigate from that perspective in terms of really getting at the heart of what the question is asking. So I think I'm going to have to take that as a follow-up.
That sounds great, and we can go ahead and move on to the next question. And this one is directed at any of the panelists who would like to jump in and answer. And it is, how exactly are you working on increasing trust of physicians to payers in order to prevent the need for pre-auth? And is there a certification process? Is this a specific opt-in product and preliminary thought, or is this a fully developed process? So on a larger scale, this could be a game changer. Okay.
Right. So I brought this up, so I'll take it. At this point, it's just kind of a concept. And remember, you're dealing with two organizations that never trusted each other. You're dealing in an environment where physicians never really spoke to each other. It was more left on the administrative side of how to deal with these two organizations. So first step, let's get the doctors in the room together. Let's start talking about agreement on clinical criteria for admission. Once that's agreed upon, let's take the next phase and let's start measuring which of the doctors are meeting the criteria moving forward. And if you see a high level of compliance with the admitting criteria, why can't we move again a higher level of trust to say, you know what, if I get a chart from that doctor, I pretty much know he's doing the right thing or she's doing the right thing, and so I really shouldn't have to get an authorization. I'm getting notification that Dr. X is admitting my patient. I know Dr. X's background. I can be assured that that doctor is doing the right thing. But I would also challenge the medical boards at some of these hospitals in their recredentialing process. And before I had left my old job, I spoke to the president of one of the medical boards at one of the facilities, and I said, what is the recredentialing process that you have for the staff here? Because it hadn't changed in greater than 20 years. And as medicine is changing and what we're focused on in medicine is changing, the recredentialing process should also change. So perhaps in order to move into a world of no authorization, you really have to look at what kind of doctors are we credentialing to admit to our hospitals as well. And again, today, these are just concepts on a piece of paper, but hopefully in 3 to 5 years, this is a place we can get to, because I do believe that is a game changer in healthcare.
Well, thank you for your insight there. And it looks like we have time for one more question today. And that is, how much of the discrepancies between payers and providers is due to poor or insufficient provider documentation? And what strategies have you used with clinical documentation improvement programs? And that question's directed at all panelists.
You want to go, Jen?
So I think Yeah, sure. So I think that's definitely an area we've been focusing on within our operations as well. Specifically with the documentation specialists that we have working in the facilities with the physicians while the patient is still there, making sure that we capture all appropriate documentation and that it's fully documented to the level of specificity that's required to support what was performed. One of the new pressures that we have that seems to be increasing these days is post-payment DRG audits. And so we need to make sure that we have clear documentation written in our medical record that can clearly support. And again, while the patient is there is the time to do it. That's also the time to have the conversations with the physicians. It's the time to have the conversation also, those clinical documentation can have a triad with the care coordination team to make sure we're seeing this documentation, is it fully supported or no? And also looking at, you know, the length of stay seems to be longer than would normally be for this type of patient. Let's make sure care coordination agrees the level of care is appropriate. Maybe this patient has some additional issues and complications that we need to make sure are in, again, that medical record, that it is fully documented. We've done a fair amount of training with our physicians to make sure they understand the value of that. Of course, this is not something they do in a physician when they get their MDs. They don't get this at med school. So we have to do a fair amount of training both formally and informally as they round through the hospital. So it is a partnership, I think, between our clinical documentation specialists, the care coordination team, working with the physicians so that they understand it's not all about making sure the hospital gets the appropriate reimbursement. It's making sure that the patient's care is fully and accurately reflected there, that any complications that could impact their indicators are also fully reflected there as well. So that's how we've been trying to make sure that on our end for the documentation, we have clean documentation should it ever be needed to support some of our efforts downstream.
Right. And what I can tell you we're doing as well in this payer-provider collaboration is, and I mentioned before, we're looking at some of the top DRGs where we're seeing clinical downgrades coming from the insurance companies, in this case United. And what we're looking at is, okay, of those DRGs, where are we seeing the highest turnover or winning the first level appeals the most? Because I have a sense that if you're winning the first level appeal a large portion of the time, there's probably something missing from the chart that once you submit the appeal and the following documentation, it's getting adjudicated, they're agreeing to pay it. So once we've identified what that missing piece of information is, let's build it into the chart so that we can prevent all these initial denials coming in and save the appeals writers all that time writing appeals. Just fix it the first time around. When you move into second and third level appeals and you're still winning and losing those, that's where we move to, you know, where the physicians have dug their heels in a little bit saying this is an admission versus no, this is not an admission. And that's when you get the two physicians together in a room and you say, let's come up with common guidelines for admitting a patient. And those should deal with most of the second and third level appeals.
Well, thank you all so much. That is all the time that we have for today, but I do want to thank Bob, Mike, and Jennifer for their excellent presentation and to our audience for participating today. Please enjoy the rest of your day, and we look forward to having you join us in the future for future webinars. Thank you.